Welcome to the Royal College of Physicians Edinburgh Clinical Conversations podcast. Each episode within this podcast series, we delve into a different medical topic with an expert speaker to join us. If you want to find more about the Royal College, then please do head over to the RCPE website and have a look at the education stream and see if membership would work for you. It offers a host of educational updates and activities such as the evening medical updates, the Royal College Symposia, and many more. Please don't forget, if you listen to our podcast, to give us a rating on one of the podcast platforms or subscribe so that it can come directly into your podcast stream.
On Friday the 24th of January, we'll hold our Medical Trainees Conference at the College in Edinburgh. You can also join online. Organised by the RCPE Trainees and Members Committee, the conference is free for RCPE collegiate, associate and student and foundation members. We'll cover managing medical emergencies, think about cases that have changed our practice, move on to navigating complexity in ambulatory care and finish with clinical lessons. We'd love to see you there. Book now on the RCPE website. Hi, and welcome to this episode of Clinical Conversations brought to you by the Royal College of Physicians of Edinburgh Trainee and Members Committee. My name's Kat Ralston. I'm a member of the T&MC and a geriatric medicine registrar in Edinburgh. And today I'm delighted to be joined by Dr Nik Rae to talk about infective endocarditis. Nik is an infectious diseases physician in Ninewells Hospital in Dundee. Welcome, Nik.
Thanks for having me.
You're very welcome. Thanks so much for coming on the podcast. I thought it might be useful just to start with a bit of a definition. So what do we mean when we're saying infective endocarditis?
Infective endocarditis is infection, usually bacterial, of the endocardial surfaces. So that predominantly involves the valves, but it can involve other structures within the heart. So septal defects, ASDs, VSDs, or the mural endocardium. And in addition to that, there's a kind of endocarditis that can be associated with intracardiac devices, so be that permanent pacemakers, ICDs, or CRT devices. And the diagnostic approach to endocarditis with or without devices is relatively similar.
Yeah, thanks for that. Why should we be bothered about it? Why is it important to us as physicians?
So I think it is one of these conditions that can present in a huge number of ways into a range of different specialties. And in many cases, particularly some of the cases that present in a more indolent fashion, it can go unrecognised or present late. It's something that maybe might be not considered initially by the physicians assessing the patient or treating the patient. And it is one of the infections with the highest mortality. So you look into the pre-antibiotic era, the mortality rates are almost 100%. So it's a really lethal infection without treatment. And the incidence, certainly from data over the last 20 years in Europe, suggests that it's increased probably about 4% per year over the last 20 years. So that the actual incidence is dramatically increasing. And some of that has to do probably with increased healthcare exposure and various other aspects of the population. So it is actually an increasingly common infection, even though it is still by numbers probably quite rare. I mean, historical data suggested incidence of about 11 cases per 100,000 population.
I think that's really important. It's sort of something not to miss, and it's also something we need to have in our minds when we're seeing people on the take or on medical wards, because it's not that common, but when you do see it, it can be devastating. So yeah, thanks for giving us the data on that. And as you've alluded to, people can present in very different ways with infective endocarditis, and it can be sort of an indolent presentation, which can be difficult to pick up. I think you've got a couple of cases where we can maybe talk around when to suspect endocarditis and what people might commonly present with, just to help us through that.
Yeah, totally. So first case, this is a 57-year-old man we were involved with who actually presented as a result of a transient loss of consciousness at home with no preceding symptoms whatsoever. So very much sounded like cardiac syncope. On the background of that, he had a 3-week history of headache, fever and sweats, and actually been seen by rheumatology in the preceding week, where there were concerns around giant cell arteritis because of these systemic features in the headache. And he had bloods that had been taken showing a raised, or kind of raised inflammatory markers. So C-reactive protein was noted to be more than 100. When he was assessed by rheumatology, giant cell arteritis was ruled out. He had various other things done, a CT head and an autoimmune screen, which were all negative. And he was kind of discharged with no clear diagnosis. before he presented with this kind of syncopal episode. Of note, he had a history of a bicuspid aortic valve, and when he was admitted, he was febrile, he was tachycardic, he had evidence of splinter hemorrhages and an ejection systolic murmur with a diastolic component to it. And as part of that diagnostic workup, he had first-degree AV block noted with prolonged PR interval. So there was a strong suspicion of aortic valve endocarditis with coexistent root abscess, particularly on the basis of the first-degree heart block. And so he was commenced on treatment after 3 sets of blood cultures were taken, high-dose amoxicillin with low-dose gentamicin, and an echo was requested. He was placed on telemetry. Part of the workup had his echo, which revealed his bicuspid aortic valve, and he had clear evidence of aortic regurgitation, and the aortic regurgitation was graded as severe. His blood cultures were positive, so he grew Streptococcus galliticus, a streptococcus that we do see is particularly associated with bowel cancer, actually. That was present in 2 sets of blood cultures, and microbiological testing confirmed that the organism was very sensitive to penicillin, so he was switched to low-dose IV benzylpenicillin before going on to have a transesophageal echo, which revealed severe AR, aortic regurgitation, with a vegetation on the coronary cusp of the aortic valve, the perforated leaflet, and evidence of aortic root abscess. So he was then transferred for emergent aortic root replacement and had a bioprosthetic aortic valve replacement. I made an uncomplicated post-operative recovery, completed 6 weeks of treatment on an outpatient parenteral antibiotic therapy schedule with ceftriaxone, and underwent a colonoscopy, which revealed he had a cecal adenocarcinoma, which was subsequently managed with right hemicolectomy after all that had settled, which was curative. So that's like a first case that kind of presents the kind of subacute features, if you like. Second case I've got is one that probably a lot of us in Scotland would be familiar with. Young chap, so 26-year-old man, found collapsed at home, fever, rigors, pleuritic chest pain over the preceding 5 days, having injected heroin into his groin 6 days ago. Only past medical history is that he is somebody who injects drugs up to 1 gram of heroin a day. Admission was febrile, tachycardic, tachypneic and hypoxic, with a loud pansystolic murmur at the left sternal edge and crackles at the bases, with chest x-ray and subsequent CT pulmonary angiogram showing multiple bilateral cavitating lung lesions. So this was suspected to be acute tricuspid valve endocarditis, probably Staphylococcus aureus, and he had blood cultures taken and started an IV flucloxacillin, which did indeed grow in the blood cultures in all 3 sets. And a transthoracic echo confirmed tricuspid valve endocarditis with a large tricuspid valve vegetation. And he actually did well, clinically responded, improved on treatment, but became quite difficult to manage on the ward. So poor engagement with care, injecting drugs on the ward, on and off the ward, and missing antibiotic doses. And so there was a discussion with the patient about 10 days into his admission around what the options were, whether he got IV treatment, for example, a long-acting IV agent, newer agents such as dalbavancin, or oral treatment. He was quite content to take oral medicines, and so he was discharged with a course of linezolid, which is highly bioavailable, and he's not represented. That was kind of a pragmatic option where we facilitated discharge with treatment to facilitate cure, which was maybe slightly earlier than we would have otherwise done.
Thanks for sharing them. Both really interesting and quite different cases. And I think hopefully we can pick up on different aspects of them as we chat through the rest of the podcast. So thinking about this clinical presentation, so they presented pretty differently, didn't they? But I noticed there was a couple of symptoms that they had together, which was this sort of fever, a sense of inflammatory or acute illness, and then a couple of risk factors that you've mentioned in terms of one of them had an abnormal valve and another one was injecting drugs, which is another risk factor. So I wondered if you can just cover, when you're sort of seeing patients on presentation, what kind of common symptoms would perk your ears up in terms of infective endocarditis, and what kind of risk factors are you looking for that might increase that risk?
Yeah, so I guess there's kind of 2 presentations, if you like. So the first case was this kind of subacute indolent presentation, so often can go on for weeks or sometimes months. And it has a flavour of almost like malignant process. It's got that kind of, a lot of the time differential diagnosis includes things like lymphoma or, disseminated malignancy. You have that kind of, often weight loss, fever, drenching sweats, often over weeks or sometimes longer. We've seen patients who have presented with symptoms for many months. That's one of the things that makes endocarditis quite difficult to diagnose, because it is, one of a very long list of differentials for that kind of illness. And those, generally speaking, kind of tend to be less virulent pathogens. So they tend to be things like Streptococcus species, virulent streptococci from the mouth, or Enterococcus. So they tend to present in a less aggressive way, in a more indolent kind of fashion, but with actually quite non-specific symptoms in terms of the patient, what the patient complains of. Whereas the other case, the young guy who injects drugs, he presented much more acutely, within the space of a few days, kind of quite acutely unwell, toxic, with sepsis. That is very typical in aggressive pathogens, particularly Staph aureus, which tends to be quite destructive and often infected valves that are normal pre-illness. So it's a slightly different illness phenotype. The similarities between both of them is that a lot of time in endocarditis, they may not have huge amounts of localizing symptoms. It may be just predominantly fever and systemic symptoms without specific localizing features that maybe needs to, I suppose, prompt consideration of endocarditis as a possibility. And risk factor wise, particularly structural heart disease. So, worldwide, rheumatic heart disease has been a major risk factor for endocarditis, although in the UK we're seeing that less. But congenital heart disease and degenerative valvular heart disease, things like bicuspid valve, mitral valve prolapse, all of these things are, valvular pathologies that can predispose to endocarditis. The other risk factors that we would commonly see in practice, particularly in hospital, would be the use of indwelling lines, patients who've got Hickman lines, dialysis lines, AV fistula, patients who've got increased healthcare exposure and being subjected to invasive procedures. These all increase the risk of endocarditis, and injecting drug use is a very, very prominent risk factor for endocarditis.
We've said that it can often be a bit of a non-specific presentation, so it might not be immediately obvious just on your history. So I wonder, is there sort of clinical signs that are going to push you towards that infective endocarditis as a potential diagnosis in these patients?
Fever is, when you look at the big studies, which have looked at thousands of patients with endocarditis and what the features are, or the common features, or how common these features are in patients with endocarditis, fever is one of the most common signs, but murmur, in particular new murmur or a change in murmur, are probably the things to look for, or the hallmarks in terms of on clinical assessment. And there are lots of other kind of more peripheral features, and we've kind of remembered them from medical school: peripheral stigmatic endocarditis, splinter hemorrhages, Janeway lesions, Osler nodes, vasculitic rash, Roth spots in the retina. And these are all actually pretty uncommon. They're all less than 10% of patients with endocarditis. You're probably more likely to see other signs of embolic phenomenon, so strokes or infarcts, rather than some of these very kind of niche, small, poorly identified or poorly described or infrequent clinical signs, shall we say. Splenomegaly and evidence of nephritis, so hematuria on urinalysis, are probably two of the other more reliable kind of clinical signs, and they're probably in the region of 10 to 15% of patients will present or have features of either splenomegaly or kind of hematuria on urinalysis. So these are other features that you might find on your assessment that might provide a bit of evidence towards endocarditis.
Yeah, that's really helpful. I think there's this massive lists of all the possible things you can find that are sort of vanishingly rare. So having things that are common and likely to help you in that diagnosis is really helpful. And it might be useful to move on to kind of investigation. So often I find once the spectre of infective endocarditis has been raised, then it kind of pushes you down a path. And more often than not, nothing comes of it. But actually, it's important to think about what investigations we need to do to really nail that diagnosis. You mentioned bloods and blood cultures as being particularly important. Our first case had a significantly raised CRP, and then both of them had positive cultures. Can you talk a little bit more about what's helpful in the blood tests that we should be sending?
Yeah, I think routine blood tests that you say are probably quite sensitive, especially for the more aggressive pathogens, in terms of showing evidence of marked systemic inflammation. So raised C-reactive protein, neutrophil leukocytosis, raised plasma viscosity, all these kind of things. They're pretty non-specific and won't give you a firm diagnosis as such, but they will just suggest that something's not right. I think the other thing is that for some of the less virulent pathogens, some people might look at the CRP and say, CRP is only 20, unlikely to be endocarditis. But for some of them, the less aggressive pathogens like Enterococcus, the CRP doesn't have to be high for you to have endocarditis. So again, I'd be quite careful about using CRP or inflammatory markers as a kind of rule in or rule out test for endocarditis. As we kind of alluded to, blood cultures are the hallmark or the cornerstone really for endocarditis. We're looking for evidence of persistent bacteremia because that's what you get with endovascular infection. It's the hallmark of endovascular infection. You have constant organisms being dropped into the bloodstream from an endovascular source. And so multiple sets of blood cultures, a minimum of 2, if not 3, using different venipuncture sites. There's less specifics around that now. Generally speaking, I would take 3 sets of blood cultures over a period of time, over a number of hours, maybe over the space of 24 hours, if the patient was reasonably well and this was a presentation over months. You don't in any rush necessarily to start treatment within the next hour. Whereas if the patient comes in extremely ill, in extremis, with multi-organ dysfunction, you probably want to get 2 or 3 sets of blood cultures off within the first hour and then just start empiric treatment at that point. And the blood cultures are often useful as well for monitoring treatment. So particularly in Staph aureus bacteremia, we very commonly will take surveillance blood cultures, and that's to assess for clearance of bacteremia because it gives you an objective assessment. Is your treatment kind of controlling the infection? Are they no longer bacteremic? And again, that gives you a bit of an objective sense we are kind of getting on top of things.
Yeah, and that's really practical advice about the blood cultures. And I've certainly had a few cases where we've had sort of non-specific, something grumbling, and actually they've been diagnosed based on just blood culture alone growing a pathogen that's consistent with endocarditis or a deep-seated infection. So I think that's really important. And you've mentioned urine dip as well, so looking for hematuria, which is a good tip. And then thinking about imaging, so we often are going for a transthoracic echo in the first instance if we've grown something or there's a high clinical suspicion of endocarditis. Can you talk a little bit more about imaging and what that's helpful for?
Sure. I mean, like you say, transthoracic echo is quite widely available and is generally first-line test. And the sensitivity of that is variable, the highest for right heart lesions in particular, but the sensitivity for TTE, transthoracic echo, is quite poor if you've got a prosthetic valve, if you've got intracardiac devices, or if you're worried about paravalvular abscess. So I think transthoracic echo may be sufficient if it gives you enough information. And for example, the patient is maybe quite frail and they're not going to be an operative candidate, then you might be content just to say, we've got a TTE, it's consistent with endocarditis. No need for transesophageal echo. But transesophageal echo remains the kind of gold standard test for endocarditis, particularly if you've got prosthesis in situ or a device in situ, if you've got a negative TTE and you've got strong suspicion, and absolutely if you've got concern around paravalvular abscess. And that leads on to kind of considerations, is the patient a surgical candidate? Because paravalvular abscesses rarely will be treated with medical therapy alone and generally would require some kind of surgical intervention. In addition to the imaging with echo, there's been a bit more interest in PET-CT in endocarditis. It's not a replacement for TOE, but it does have a role, probably more so in prosthetic valve endocarditis. It's a lot less sensitive for native valve endocarditis. It has an additional role that it can locate metastatic foci of infection. So if you've got small discitis or mycotic aneurysm that may, again, support the diagnosis of endocarditis, that you've got another endovascular focus, that can confirm the diagnosis of endocarditis. Although PET-CT, there are issues with access and availability. It's often not that practical to get a PET-CT, when you can get a TOE maybe within the space of a few days.
Yeah, you might struggle to get that in the district general, but really interesting to know that there's other imaging available, particularly for sort of prosthetic valves and things. And I think that's helpful to think about when to move on to TOE, because often you're left in a situation where there's been sort of a question about endocarditis, there's been nothing on the cultures, and they have a TTE that doesn't have any endocarditis but cannot rule out endocarditis, and you're in this sort of situation where you're like, now what? So it sounds like we're going on clinical suspicion. So really, if there's a high clinical suspicion and the patient is fit enough, then going on to TOE is useful. And if not, then you can maybe just leave it there with the watch and wait situation. Is that fair?
I think so. Sometimes, especially if patients have got relatively subacute presentation and it's one of the possible diagnoses, I think you can sometimes observe and, again, keep an open mind. And it's very easy to say, just do all the tests, but sometimes that can be quite aggressive and quite blunderbuss. And sometimes you're taking your blood cultures, you're working up other diagnostic possibilities. I think it's totally reasonable sometimes to park the idea and observe progress. And again, you can revisit it if things change.
This nice pragmatic approach, which I'm all for. Okay, so we're talking about investigations, and one thing that's always talked about is sort of Duke's criteria when infective endocarditis is being talked about. And I'm aware it's been sort of updated recently, so it might be useful just to talk through what that looks like now, what the changes have been.
Duke's criteria has been used for a long time, mainly as a research tool, to be honest, to kind of, if you like, supply adequate evidence of endocarditis. But it's definitely got a use in screening patients and, if you like, assessing how strongly the possibility of endocarditis is. So the Duke's criteria was updated in 2023, and as per kind of previous, it's kind of diagnostic of endocarditis if you have 2 major criteria, if you have 1 major and 3 minor criteria, or if you've got 5 minor criteria. The major criteria are kind of divided up into microbiological and imaging. And so the microbiological requires a typical organism in 2 sets of blood cultures, either your virulent streptococci, Staph aureus, or your typical endocarditis pathogens. We include other less commonly seen organisms like Hatschek organisms, which is a group of fastidious organisms that are known to have a proclivity for causing endocarditis. Or if you've got a non-typical organism in 3 sets of blood cultures, that would be your major kind of microbiological diagnostic criteria. The imaging side of things, they use echo as the gold standard. So if you've got vegetation or an abscess, pseudoaneurysm around the abscess, or new valvular regurgitation, they've kind of changed that a little bit. So they used to say worsening valvular regurgitation, but they've kind of taken that bit out of it and really have elected to kind of pursue if you've got new valvular regurgitation. I guess probably because it's a bit more subjective, worsening valvular regurgitation. If you've already got a pre-existing dysfunctional valve, that might not entirely be supportive of endocarditis. And they've included PET-CT in their imaging modalities. So if you've got increased uptake on a native or prosthetic valve, either aortic graft or other prosthetic material, again, that is a major criteria for endocarditis. The minor criteria are kind of similar to previous. So they've got things like predisposing heart condition or injecting drug use, the presence of fever, vascular phenomenon. So that includes things like infarct, mycotic aneurysm, distal mycotic aneurysms, immunological phenomena, so some of the stuff we've been speaking about already, so evidence of glomerulonephritis, Osler's nodes, Ross spots, etc. Or if you've got either microbiological evidence or imaging evidence that is not meeting the major criteria, but is still, if you like, has a suggestive flavour towards endocarditis. It's a pretty laborious kind of criteria. If you're trying to kind of go through everything, you'll often have to look it up and just tick them off. Obviously, some are more straightforward than others in terms of the major criteria, but it is still a useful tool for seeing how much weight you've got to the diagnosis.
Yeah, I know that's definitely not on the top of my head. I've been looking it up. I think that's right, and it sort of helps a bit with cognitive bias, doesn't it, to actually have a checklist ruling in and out different features to help you towards that diagnosis. Sometimes you can find people have blood culture negative endocarditis or non-infective endocarditis, which can be pretty tricky. Any words on that?
Yeah, I mean, blood culture negative endocarditis is a really difficult entity. So I would say the majority of true blood culture negative endocarditis, or at least a significant proportion of them, are culture negative because they've been given some antimicrobial therapy before cultures have been taken. So they're probably due to things like streptococci or enterococci, and we've already given some treatment, and it may have been oral from GP or primary care, or they may have been started on something for another condition, be it pneumonia or urinary tract infection. That's partially treated something, and blood cultures have not been taken. So a significant proportion of culture negative endocarditis is due to just the standard pathogens, but we've not detected them. And sometimes we can detect them through alternative testing. So complex testing like 16S ribosomal sequencing may be helpful, PCR techniques. The other kind of classic blood culture negative endocarditis are caused by fastidious organisms, so things like the Hatschek group that I was speaking about, but you also see things like Coxiella burnetii, Bartonella, Brucella, Whipple's, and sometimes it's fungi as well. Although I would say fungal endocarditis, people tend to be much more unwell. It's to be a really quite aggressive illness. Vegetations tend to be large with lots of embolization. And often you can, particularly with yeasts anyway, you can grow candida if you take enough blood, inoculate it into the blood culture bottles. And like you said, there are non-infective causes, so it's called morantic endocarditis, commonly seen in patients with malignancy, particularly things like pancreatic, gastric cancer. Disseminating malignancy may have a kind of prothrombotic kind of endocarditis, which is sterile, it's not infective. And again, the only way you can know that is with taking large sets of blood cultures of antibiotics. And that will give you some reassurance that there's not persistent bacteremia there. And sometimes it is difficult to not cover for the possibility of bacterial infection if there's uncertainty. And obviously things like Liebman-Sachs endocarditis, which is extremely rare in the context of SLE.
I think that just underlines how important it is to try and get blood cultures before you're starting broad spectrum antibiotics on patients, particularly if they're presenting in that kind of indolent, non-specific way at the front door. You don't know where the infection's coming from. So we'll maybe move on to management. So I guess that segues nicely. When should we be thinking about starting empirical antibiotic therapy at the front door or on presentation?
I think it depends in many ways on the presentation. I think for the acute presentation, the patient who is acutely ill, like for example, the case of the young guy who injects drugs and he presents very acutely, empirical treatment for him should really be targeted against the likely pathogen, which in his case is going to be Staphylococcus aureus. So in the UK, we would normally use things like flucloxacillin at high doses with things like vancomycin with low-dose gentamicin if there's a significant penicillin allergy. So local British recommendations do suggest that if the patient is severely ill, so has evidence of severe sepsis and risk factors for resistant pathogens, and that includes injecting drug use or previous isolation of MRSA or more resistant gram-negatives like extended spectrum beta-lactamase producing organisms, that a kind of broader spectrum regimen is given empirically in those patients who are really kind of critically ill, so vancomycin with meropenem at high doses. And again, that's with the caveat of rationalizing that once you have blood culture results available to kind of guide your treatment. For those who present in a more subacute fashion, I think depends how ill they are or what the concerns are. I think some patients obviously you come into ambulatory or ambulatory care settings and endocarditis is a possibility. And for them, you might want to give them any treatment at all. You might just take the blood cultures over a period of time and send them away and bring them back. If the patient is febrile and maybe unwell and needs hospital admission, you take your blood cultures over a period of time, and then you would probably start, for those subacute presentations, high-dose amoxicillin, so normally 2 grams every 4 hours, with low-dose gentamicin, so normally 1 milligram per kilogram twice a day, and with vancomycin, gentamicin, low-dose, if there's really significant penicillin allergy. And I think that's what we would probably suggest for most patients, at least in the UK. Prosthetic valves have a slightly different approach because they are more likely to have slightly different organisms, so particularly coagulase negative staphylococci are commonly seen in prosthetic-associated infections, so vancomycin with gentamicin would be given for them, and sometimes with rifampicin added after a period of a few days. There is this kind of hypothesis that rifampicin will enhance the antibacterial effect of the regimen because it penetrates into biofilms. It's like films produced by staphylococci on prosthetic material. And the evidence for it is actually not that strong, but at the moment we still are using it for a lot of prosthetic infections like prosthetic endocarditis.
Yeah, absolutely. And you're, of course, going to be guided by, your local microbiology guidelines and your infectious diseases colleagues to guide you on that. And so that's sort of the empirical therapy. So make a decision on how sick the patient is as to whether you need to start it now or can wait a bit while you get some tests done. And then, of course, we've alluded to the fact that you're going to rationalise that as quickly as possible. So get them onto something definitive in terms of antibiotic therapy. And I think that will just depend on what they're growing, Nick, is that right?
Yeah, absolutely. I mean, it's generally guided by what you find. And for most streptococci, it will be a benzylpenicillin-based regimen. For Enterococcus, most Enterococcus species, Enterococcus faecalis, amoxicillin. And for Staphylococcus aureus, if it's MSSA, so methicillin-sensitive Staph aureus, flucloxacillin with vancomycin if it was MRSA. And some other agents that may be used for definitive treatment. So ceftriaxone is sometimes used in outpatient parenteral antibiotic therapy settings for patients who have improved, have done well on treatment and no longer require inpatient stay. And we sometimes do use for definitive treatment vancomycin and synergistic gentamicin for really when there's severe penicillin allergy or when there's these more resistant organisms, so MRSA, coagulase negative staphylococci, and associated with prosthetic infection, and sometimes some of the more difficult to treat enterococcal species like Enterococcus faecium. But yeah, it's a slightly more complicated regimen to give because obviously it requires some drug monitoring and things like that, particularly with the vancomycin.
Yeah, vancomycin and gentamicin can always be really tricky on the wards, can't they, sometimes? So if we can get away without them, that's always a good thing, I think.
Absolutely.
And you mentioned penicillin allergy a few times, and I just wonder if it's worth mentioning flying the flag for penicillin delabeling, if we can, for these patients.
Oh, I'm all for flying that flag. I think penicillin allergy is really overrepresented if you look at patient records. A lot of patients are labelled with penicillin allergy, which is an intolerance rather than a true allergy. And the fact of the matter is that most infections in general are best treated by beta-lactam antibiotics, assuming they're susceptible to them. So there's a study a number of years ago looking at methicillin-sensitive Staph aureus infections, quite a big study from the States. And again, patients that were given vancomycin rather than an anti-staphylococcal beta-lactam agent were about 35% more likely to die than those that received the beta-lactam-based agent. That's in a kind of sensitive Staph aureus where you're giving really inferior treatment because of probably concerns around penicillin allergy. It's not just something that we harp on about for the sake of it. It can have a significant impact on outcomes for patients. So it's critical to take an allergy history and find out when the allergy was, if it was very historic, in childhood often. That obviously is a lot less concerning than if they say, I took penicillin and I developed widespread angioedema, urticarian angioedema, which is a completely different kind of thing altogether. But in patients who don't have clear features of type 1 hypersensitivity, all of them can be delabeled in hospital. So small dose of either amoxicillin or flucloxacillin observed. And then if tolerated, we can delabel that allergy and put them onto a beta-lactam-based antibiotic. So it's something that we actively encourage and do almost on a daily basis in ID.
Yeah, I think we should be opportunistically doing it more. And there's some really useful guidelines I've seen on that. So we can link that in the podcast notes as well, which I think might be helpful for the listeners. And then sort of just thinking, there's often sort of a lot of chat and decision making around how long we're giving antibiotics for and what route we're giving antibiotics for and how we're making that judgment. So, IV versus oral. And yeah, so do you have anything to tell us about that?
Yeah, so I guess the duration of treatment for endocarditis for most cases will be 4 to 6 weeks. There are a couple of regimens with very, very sensitive organisms, streptococci, that can be given for 2 weeks, although these are quite uncommon. Generally speaking, 4 to 6 weeks of therapy is the norm. And I would say the tendency is to give longer durations of treatment if you've got prosthetic valve or prosthetic associated infection, or if you've got widespread embolization as a result of the endocarditis. So historically, the treatment has been based around regimens using kind of quite prolonged parenteral therapy, often with agents like ceftriaxone or glycopeptides on outpatient parenteral antibiotic therapy programs. But there's really good evidence, actually, that oral therapy in selected patients is as effective as intravenous. And it kind of goes against what's quite dogmatic practice and has been for decades in ID. And actually, when you look back through the evidence, and the evidence stretches back as early as 1991 in terms of randomized trials looking at oral therapy versus IV in patients with endocarditis, we've got actually quite good evidence to support the use of oral agents in carefully selected patients, not in everybody, and the outcomes being comparable. It's something that probably hasn't gained that much traction. There's a lot of anxiety around people doing stuff that they've not done before. And a lot of us as doctors, we're used to what we've always done. And I think there's a bit of inertia around that.
Yeah, absolutely. People having osteomyelitis as well from sacral sores and having sort of 6 weeks of IV, and we're sort of trying to move away from that now. So I feel like it's kind of a similar trying to break the mold and get through that. And maybe that patient, the second case you talked about when the patient maybe had a bit of a chaotic lifestyle and was challenging to manage on the ward, is something around that pragmatic sort of individualized decision-making for certain patient groups. What do you think?
Yeah, absolutely. I mean, I think, again, a lot of these decisions, I think when you discuss it with patients, if you say to patients, these are the options, and in your case, actually, you fit a lot of the criteria that would make you appropriate for oral treatment. There's giving them oral treatment because it's indicated, and there's giving them oral treatment to reduce harm. And there have been some big studies in the States, for example, that are very similar to this guy's case that we're talking about, the young guy with tricuspid valve endocarditis, suggesting that, if you give antibiotics when patients want to discharge against medical advice, actually that dramatically reduces the risk of readmission and subsequent admissions with the same illness. So I think it's important that if patients, for example, are expressing, views that they want to leave hospital, is not just to let them go without any treatment, but is to try to find a pragmatic middle ground. And even though for them, we might want to keep them in hospital for longer, to give them longer in terms of IV treatment, we want to try and reduce the risk of harm and, facilitate, if you like, a next best option. And like I said, the individual decision-making for oral treatments, I mean, we certainly speak to patients quite a lot and explain to them about the risks of IV versus oral. And again, IV therapy for 6 weeks requires a long-term line. It's daily injections versus taking some tablets. So there are risks associated with having a PICC line in place. And as long as you meet the necessary criteria for transition into oral treatment and you're using an appropriate oral agent should be as effective as IV.
Yeah, and it's good for sort of realistic medicine, isn't it, as well, which we're all sort of being encouraged to practice.
Absolutely.
And I think you're so right about that discharge against medical advice. Sometimes people can have the attitude that, well, if they're discharging, then they leave and we don't give them anything. But actually, I think we should be making it as safe as possible for this patient group who are at significant risk of harm. So doing your best to try and ameliorate that risk feels really like a good plan. And I guess the other thing I just wanted to pick up was for the first case you talked about, you mentioned the ECG on that patient. I'm just thinking about complications. So when things maybe aren't straightforward with patients with endocarditis, can you tell us what the significance of that is and the purpose of ECG monitoring in this patient group?
Yeah, so I think particularly for aortic valve endocarditis, ECG is very helpful. So if you find that you have a kind of progressive prolongation of the PR interval, that may indicate evolving aortic root abscess. So that's something that we would consider in patients with aortic valve endocarditis as a kind of relatively routine test. It might be that you do it once every, especially if they're just in the door, you might do it 2 or 3 times in the space of a week, just to kind of chart things.
In addition to first degree heart block, they can also develop second or third degree heart block. And particularly in the case that we discussed with the guy who had what sounded like a syncopal episode, obviously that would be a kind of major concern. Indeed, that was one of the reasons why he was placed on telemetry on admission.
I think, in terms of other complications that can arise from endocarditis, certainly we see widespread embolization, so strokes or systemic emboli, so that might include peripheral emboli or mesenteric infarction. In right-sided endocarditis, as was the case with the young patient that we discussed earlier on with tricuspid valve endocarditis, you can get septic pulmonary emboli, so these widespread cavitating lesions throughout the lungs that can sometimes progress into empyema. You might have other distant infections, endovascular infection, mycotic aneurysms, or seeding into other sites, so be it spondylodiscitis, psoas abscess, septic arthritis. So there are lots of other kind of complications that may arise. What I would say about them is a lot of these probably don't change a huge amount about the duration of treatment. Some of them obviously may require surgical intervention, particularly the aortic root abscess or kind of paravalvular abscesses that we're talking about. But
some complications such as spondylodiscitis or psoas abscesses, particularly if they're small and can't be drained, may not actually change your treatment plan at all because you're still talking about a duration of around 6 weeks or thereabouts.
Yeah, it's useful to know about the complications that can happen, particularly for that aortic root, and thinking about when they might need cardiothoracic surgery, which is when we're talking about abscesses. And the other thing, of course, which we're not going to get into in detail, but is sort of infective devices. And I think that's a very specialist area, isn't it, Nick? But that's another reason why, cardiothoracics might need to be involved with the patient.
Yeah, absolutely. I mean, devices are super complicated. Cardiologists love putting them in, and obviously they have got huge benefits for patients, but they can be really complicated if you've got a device-related infection. And some of the considerations around device infections, you can have isolated pocket infection, you can have infection involving the lead, you can have infection involving the lead with associated valvular endocarditis. So those are all kind of slightly different. And for us as ID physicians, we've got an infected device, we always just say we want to take it out. But that's a lot more complicated if the device has been in for an extended period of time. It's not simple to extract the device. It may require surgical extraction. And I think the other thing to bear in mind is the indication for the device. If it's a patient who's got complete heart block that's totally pacemaker dependent, that's a bit different from some other devices where it may be like a primary prevention ICD or a CRT. They say, well, actually, we could take that out for a period of time. So I think they're really nuanced decisions, and it needs discussion with experienced cardiologist and often cardiothoracic surgeon.
Yeah, absolutely. So I think just phone a friend and it's MDT discussions if you're having some patients with a device infection or complications. Okay, well, I think we've covered a lot of ground there, Nick. I wonder whether we might finish off with anything you want the listeners to take away, top tips or take-home messages about infective endocarditis.
From a specialist point of view, and again, it's very easy because I see them often when it's been considered or down the line, but I would say endocarditis is something you should always have a new differential for any subacute illness. So when you've got multi-system pathology and the differential diagnosis includes malignancy or vasculitis, endocarditis should be on your list. Taking a few sets of blood cultures is relatively cheap to do. Actually, you might diagnose patients very, very early in the illness. And we've had patients who've presented with large splenomegaly, about to proceed for splenectomy for presumably low-grade lymphoma with acute endocarditis with symptoms over many, many months. So again, it highlights the importance of keeping it in a differential and thinking about it. I guess that's kind of comes up to my second point, blood cultures, and preferably before antibiotics. So just make sure you get the blood cultures off early and ideally multiple sets. And I think the other thing for me is around challenging dogmatic practice. We all are in that phase where we're used to doing what we're doing, and change is sometimes difficult to adapt to or accept, but we need to practice evidence-based medicine and do what's best for patients and go with what the evidence says. And I think endocarditis at the moment is quite slow in terms of widespread use of oral antibiotics, but certainly the more that we're doing it, I think the more widespread it will become.
Thanks so much, Nick. That's really good take-home messages, and I've certainly learned a lot through our chat, and I hope our listeners have enjoyed that too. Thanks very much for coming on the podcast.
No worries at all. Thank you very much for having me.
The T&MC sister podcast, Career Conversations, supports medical students and trainees with career guidance and progression, as well as professional development. We wish to recommend our Demystifying PACES podcast series on career conversations. As some of you may know, in late 2023, MRCP UK updated the PACES exam format, so we developed this new series to support PACES candidates. Episodes cover exam organisation, calibration, every PACES station including key changes, and candidate perspectives.